I invite here for therapy, to speak about therapy, Professor Stathis Kastritis from Medical School, National Capodstrian University of Athens. His work really was a great step forward to light chain amyloidosis. Professor Kastritis, please.
Thank you, Daniel, and I'm very happy that I will continue from where Giovanni Palladini stopped. So we'll discuss about the treatment of the disease. I will also start with the presentation of a few cases. These are patients that have already been diagnosed. So the question here is not whether they have AL amyloidosis. All of them, they have confirmed AL amyloidosis. You can see the first case is a 69-year-old person with no-name gas. You can see the free light chains, high levels of free light chains, 15% plasma cells, T1114 positive. You see the levels of the anti-BMP and the troponin. You see low serum albumin. You see proteinuria. This is a multisystemic involvement that includes the heart, the kidneys, and the liver. The second case is a 63-year-old male, again with a no-name gas. Again, a patient with cardiac involvement and proteinuria, again with T1114 translocation. But as you can see, this is a case very similar to the one that Sorina asked. A patient with 30% plasma cells. A patient who has myeloma and, of course, has myeloma by definition due to the increased level of the plasma cells in the bone marrow with 1q21 and T1114 and stage, we will see what stage cardiac involvement and renal involvement. The third case is a female, 75-year-old, again with cardiac involvement, but probably not as bad as the other ones, and the tumor burden and the free light chain burden is lower and without any significant cytogenetic abnormalities except for Thylacine 13q, which actually means very few things with the current treatments. And the final patient is again a patient with very advanced cardiac involvement and very high levels of free light chains and T1114. So these are very typical cases. I think these are the patients that we see in our everyday practice. Patients who are in their mid-60s, just before their 60s, maybe above their 70s. Cardiac involvement, the main problem. Usually, many of these patients have also renal involvement, and many of them will also have some other comorbidities. So the first question is, what is the prognosis? And I'll hopefully, because I don't have so much time, Giovanni Palladini covered the issue of the risk assessment. You all know the importance of stage 3B and the Mayo stage 2012, the revision. However, I have to note, and this is something that we have to consider today, that with the current treatments, things are not as they used to be when these staging systems were developed. So you can see here, for example, that if you take a modern cohort, these are data from our center, you can see that stage 2 and stage 3A actually have a very similar outcome. And if you take Mayo 2012, you can see that stage 3 and stage 4 also have a very similar outcome. So things have changed since then, and why? Probably because we have treatments like bortezomib, which was not available at the time these staging systems were developed, and we have also daratumumab and many more. Giovanni already presented the importance of longitudinal strain assessment in patients with cardiac amyloidosis. This is something that is further validated. You can see the importance of high GLS, where the lower the better, the more negative the better. Less negative, it's worse. And this is proposed as an additional staging factor for patients with cardiac AL amyloidosis. And finally, we have to remember, because most of the patients that I showed you also have renal involvement, that many of these patients have a risk of progressing to dialysis. And this is not trivial. This is very important, because this is a huge deterioration of their quality of life. Their life changes because they go to dialysis. And as Giovanni pointed, the importance is here. To diagnose early before you see a significant reduction of eGFR and a huge amount of proteinuria. There are some new biomarkers that can be helpful. We are about to publish now work regarding cystatin C in patients with AL amyloidosis, which shows that it can be a very sensitive biomarker that can identify patients at very high risk. So, these are the patients. You already heard about the staging. And the question is, okay, so how should I treat these patients? The first one has stage 3A disease by Mayo Stage 2004, stage 4 by revised Mayo 2012. I think having two staging systems is already too complicated. And renal stage 2 based on the system that Giovanni Palladini has proposed. The second patient, Mayo Stage 3A, Mayo Stage 4, and renal stage 2. Very similar if you consider the involvement of the organs. However, one of these patients has also 30% plasma cells, 1q21, T1114. So in the surface, they may seem quite similar, but there may be significant differences. The third patient has, let's say, slightly earlier disease, Mayo Stage 2, revised Mayo Stage 2, renal Stage 2, and I have to note that peripheral neuropathy, because these staging systems do not capture every organ that can be affected by AL amyloidosis, but the dissemination of the amyloid and the pattern of organ involvement may be extremely important when we decide treatment. And the fourth case, stage 3B, the one that we want to avoid. You remember very well the survival care, which is like this for patients with stage 3B. It's the worst. And renal stage 1. You can see here that this patient has indeed very bad prognostic features and 15% plasma cells, T1114 present. So these are the patients, but before we start treatment, we have to set the goals of the treatment. And what are the goals of therapy for patients with AL amyloidosis? First of all, we have to remember that in AL amyloidosis, we have two levels of response. The first level is the hematologic response, okay, which is the absolute requirement in order to improve the survival of our patients and in order to improve the organ function. However, what is the optimal depth of response? Of course, someone will say complete remission, and I agree, but we have to have data to support that, because reaching to complete remission, it's not easy. Also, how fast do we need to reach to the response? Do we have the time to wait, just adding therapies one after the other until we reach our goal? Do we have 2 months, 3 months, 6 months, 12 months to reach to a response? And we have to remember that in AL amyloidosis, the response criteria, as proposed by Giovanni Palladini almost 13 years ago, are not the same as in myeloma. They are very similar, but they are not the same. They are mainly based on the measurement of the free light chains and the ratio, all right, and their difference. So we have to remember that there is a significant change here compared to myeloma response criteria. But what is important is this. This is what happens when you achieve CR, and this is what happens when you achieve PR. The difference between a complete response and the partial remission is huge. So just by inspecting this curve, I can tell you that this is not good enough. However, the second level of response that we have to remember is the organ response. And we have to remember that organ response depends on the hematologic response. It is very, very unlikely to see a clinically significant organ response in a patient that has not achieved a good hematologic response. We have to remember, however, that the organ response lags behind the hematologic response. So first you will have the hematologic response, and then you expect the organ response. And you have to remember also that the time between hematologic response and organ response may be long. It's not something that you will see next week or in 1 month. It may take several months or even years to see a clinically significant organ response after you have achieved even a very fast hematologic response. And finally, and this is very disappointing, we have to remember that in some cases, the damage that has been done to the organs by the amyloid may be completely irreversible. For example, a very typical paradigm is patients with renal stage 3 disease, low eGFR, very high levels of proteinuria, which very rapidly lose their renal function and end up in dialysis despite a very good and rapid hematologic response. So sometimes we are just too late. Of course, the hematologic remission improves the probability of organ response. So how deep can we go? We can go to complete hematologic response. We have to remember that the definition of complete hematologic response has slightly changed because you may see, for example, if you use daratumumab, positive IgG kappa immunofixation, which is daratumumab. But if you see it in a patient with lambda chain amyloidosis, that's fine. You may not reach to have a normal free light chain ratio because the uninvolved light chain is very low because of daratumumab. So it may need to think a little bit. But also we can assess MRD. We can assess the presence of residual clone in the bone marrow with very sensitive techniques, and there are data indicating that if you achieve MRD negativity, the probability of organ response substantially increases, and also the probability of hematologic relapse, so that your plasma cells will come back and the light chains will come back, also is reduced. However, the previous slides were based on the bone marrow evaluation of MRD with next generation flow cytometry. However, now we have mass spectrometry evaluation of the presence of very, very small amounts of free light chains in the peripheral blood. This is not a technique that is widely available. Even the machine is not for sale in every country in Europe, plus that it is extremely expensive. But what this data show is that if you have MRD in the bone marrow, of course you need to, you avoid second line therapy, but the overall survival is different. But if you have MRD negative in the peripheral blood, which means you don't have any detectable free light chain with mass spectrometry, even in patients with complete hematologic response by the ISA criteria, there is a significant difference. So, what matters in AL amyloidosis is mostly the absence of circulating toxic amyloidogenic light chain. So, ideally, this should be the goal of therapy. And the question, of course, is how do we get there? Now, how fast do we need these responses? So these are landmark analyses from our center. You can see that if you achieve a VGPR, at least a VGPR, which means DFLC below 40, after 1 month, you have better outcome, of course. And after 3 months, yes, okay, fine. This is, I think, something that is expected. These are landmark analyses. Okay, so these patients have survived already 1 and 3 months. But I think this is most important. So this green is the patients that they achieved at least a VGPR at 3 months. And here are the patients that achieved a VGPR in the first month. These and these have achieved VGPR. But there is a difference here of just 2 months. Just 2 months of delayed of good hematologic response is associated with much poorer outcome. So, you have to achieve a very fast hematologic response because you have a toxic circulating light chain which kills cardiac myocytes, kills the kidneys. So you have to do something very, very fast. Also, what is very important is that we usually have small clones, and if you have a patient who receives a treatment and after 1 month has failed to achieve a very good partial remission, if you continue the same treatment, the probability that this patient at 3 months will have achieved a VGPR is 25%. Which means that you have a 75% chance that you will still remain in a poor hematologic remission. So probably for some patients, we should change treatment very, very fast, and this is something that I will show you here. So this is, let's say, is the conservative approach to evaluate treatment and changing treatment, therapy. So if you have a patient who after 1 cycle has not achieved the PR, yeah, I think this is very bad. It's not very common today. It's something that we don't see with DARA-VCD. Most patients who are treated with DARA-VCD are having a PR within the first month, but maybe with VCD we have several patients who fail to achieve at least a PR within the first month. And if you have failed to achieve a PR within the first month, yes, probably you need to do something with the treatment. You have to change the treatment. Or if you have failed to achieve a very good partial remission after 3 months, then again you have to reconsider the treatment. So these are, let's say, goals that are, in my view, conservative. And probably are okay for patients who have early renal involvement and not severe cardiac dysfunction. Because I think that for the other patients, things are urgent and we have to be very fast. And you can see here what happens when you delay just 1 month or 2 months to achieve a hematologic remission in patients with stage 3B disease. It may be too late. So I think that for patients with severe cardiac involvement, stage 3 disease, stage 3A, stage 3B, you have to evaluate your patient, of course. You have to be very ambitious with the treatment. And you have to consider changing the treatment, adjusting the treatment if you have failed to achieve a good hematologic response after 1 month, especially in patients with small clones. So, just to summarize the goals, we need deep hematologic responses, rapid hematologic responses, and the difficult part here is that we need to achieve this with low toxicity because the patients are very frail. I think you already showed that the patients that we are going to discuss are frail with multiple organ involvement. And what we have today, we have all these regimens. Mainly we have VCD or DARA-VCD. Let's be honest, these are the regimens that we use today. We have the Andromeda data. However, we have to remember that the randomized studies, both EMN03 and the Andromeda, excluded patients with stage 3B disease, so we have to be careful in the interpretation of the results. And the best results were achieved with the Andromeda, which is, as you know, a randomized study which compared daratumumab with VCD versus VCD in newly diagnosed patients with stage 3A, 2, or 1 disease, and patients with stage 3B were excluded. So the primary endpoint of this study was the complete hematologic response rate, which, as we showed, is very important for the outcome of the patients. You can see that the initial analysis was 18% for VCD versus 53% for DARA-VCD. And in the final analysis, after the completion of the 18 months of maintenance, it was almost 60% versus 19% for VCD. So substantial improvement in the rates of complete hematologic remissions. However, still with DARA-VCD, 40% of the patients failed to achieve a complete hematologic response. So yes, we have a substantial improvement, but still almost half of the patients, 40% is almost half of the patients, did not reach what we think is optimal. What about organ responses? You can see that at every point, the cardiac and renal responses with DARA-VCD are at least twice the organ responses with VCD. However, and despite the fact that 40% of the patients achieve complete cardiac response, so they almost normalize their NT-proBNP, almost half of the patients failed to achieve an organ response. So we have substantial improvement over what we had with VCD, but still we are behind of our target. Still, half of the patients fail to achieve a CR or an organ response. Of course, achieving complete hematologic response is associated with substantial improvement in the outcomes, whether you achieve that with DARA-VCD or VCD. But with DARA-VCD, you have 3 to 4 times higher probability of achieving this target. And this study also showed that addition of daratumumab to VCD improves the overall survival of patients with AL amyloidosis and stage 1, 2, or 3A. And I think here is a very important slide, because this is actually the first study that showed survival improvement after comparing two contemporary regimens. The previous was the comparison of bortezomib MDX versus MDX, which is not used today but there are some exceptions, but we don't use it today. Here, we do see overall survival improvement. However, I have to point this here, and I will discuss this in the next few slides. And these improvements, of course, were seen across cardiac stages and patients with or without T1114. So, that's it. We have DARA-VCD, end of story. This is the treatment. Well, should all patients receive DARA-VCD? Again, I come to this point here. So, during the first 2 months, the mortality was identical between DARA-VCD and VCD. So, there is something happening there. Could be that the disease was already very advanced in these patients and could not be saved. Or it could be that the treatment may be slightly more toxic than needed. And the common denominator here is VCD. It's not daratumumab. So, is DARA-VCD the optimal regimen for every patient with AL amyloidosis? And here I want to show you an analysis which shows the toxicity during the first 6 cycles where patients receive DARA-VCD or VCD, and toxicity after cycle 6 where patients received only daratumumab. You can see that the toxicities here are more or less similar, with the exception of infections. And something changes after cycle 6. What changes is that after cycle 6, patients do not receive bortezomib, do not receive dexamethasone, and do not receive cyclophosphamide. And many of these toxicities are related to bortezomib. And this is something we have to remember, because bortezomib is a very important drug for the management of AL amyloidosis. So this is why we tried to avoid bortezomib in patients with very advanced cardiac amyloidosis. So this is EMN22, a prospective phase 2 study that enrolled 40 patients with stage 3B disease, those who were excluded from Andromeda. They were not included in Andromeda, these patients, and they were treated with daratumumab alone for 3 months. And if they had not enough response, then we could add bortezomib. So the 6-month survival is 65%, and someone will say 65% 6-month survival, it's not very impressive. However, the historical controls is 30% or 35%. We know this is the outcome of patients with stage 3B disease when they are treated with bortezomib-based therapies. So yes, indeed, there has been an improvement in the outcome of patients with stage 3B disease, but still we lose 40% of the patients within the first 6 months. Still very disappointing. Of course, it's very important if these patients achieve a complete hematologic response. And what is the most impressive, in my view, is that in these patients who had a median NT-proBNP of 16,000, that's very high, 50% of the patients achieved a cardiac response. And some of these patients achieved a very good or a complete cardiac response, which means that they had a substantial decrease in the levels of NT-proBNP. So, what is the message from me? We can still save even patients with stage 3B disease if we treat them carefully and try to avoid the toxicity of the treatments that we use. We need to improve. There are prospective and retrospective data all showing the same thing, that in stage 3B disease, when you use DARA VCD or DARA, you lose 40% of the patients. Do something to avoid this early mortality. So this means that the decision of the treatment should be adapted to the risk of early mortality, which is more or less shown by Mayo stage, the presence of Mayo stage 3, mainly stage 3B. And in these patients, we should try to use a modified regimen. Do you want to use DARA monotherapy? Do you want to use DARA with lower doses of bortezomib? I think everything of this is feasible. And try to avoid large doses, high doses of dexamethasone. So going to the first patient with stage 3A disease, we started therapy with DARA VCD. After 1 cycle, the patient achieved VGPR. A complete hematologic response after 3 cycles, fantastic. No renal response. There was some cardiac response. NT-proBNP went down to 3,000 from about 7,000. This is good. The patient felt better, but still, this is advanced cardiac disease. And the question is, what are we going to do next? This patient is 69 years old. First of all, we have to wait a little bit. We have to remember that the depth and the improvement of cardiac response may take time. This is a study that we did, a collaborative study that was led by Eli Mukhtar from Mayo Clinic. We all contributed data, and you can see that achieving a cardiac shark may take 6, 12, 24 months. So you may need to wait 6 months, 12 months, 24 months. And it's important to say to the patient that, you know, you have a response, you have an improvement, this may continue, and we have to follow, and we have to continue therapy. Because maybe in 1 or 2 years, your cardiac function may have improved substantially. So we need to give the patients hope. And the hope is that if they achieve a very good cardiac response, which this patient actually did, you may have a very good outcome. And this is the survival of patients who achieve a complete cardiac response. And the blue line is the general population. And you can see that these are very, very similar. So patients who achieve complete cardiac response, and these are usually patients who achieve complete hematologic response, they can be expected to live a long and good life. And I think this is a very important message for the patients. Now, the second patient who had stage 3A, very similar to the previous one, started with DARA VCD, but after 1 cycle, is in PR. After 3 cycles, still in PR. The light chains dropped. They are around 80, still not VGPR. No renal response, no cardiac response. So what are we going to do in this patient who is on DARA VCD after 3 cycles of DARA VCD? And I think this is a challenging case. When we face these cases, this is challenging. First of all, this patient had 30% clonal plasma cells. Okay, so this is the patient with myeloma in which you start wondering, what can I do? Maybe I did not give enough therapy. But this is also a patient with cardiac involvement, renal involvement, and many other complications related to amyloidosis. So, yes, indeed, it's important to evaluate the clonal tumor burden, and indeed, patients who have more than 20% plasma cells, or even more than 10% plasma cells, they have a worse outcome. This is the study by Eli Mukhtar in leukemia. These are data from our department. I just analyzed them 2 days ago for this presentation to show, do we see something different? And as you can see, we see exactly the same thing. So indeed, the bone marrow tumor burden is a variable that we have to consider. Also, the presence of T1114. We know that with bortezomib alone, things are not so good. But we can salvage these patients. In the Andromeda, 40% of the patients had T1114. And you can see here that with the addition of daratumumab, there was no difference in the outcome of patients with or without T1114. So it seems that, indeed, the addition of daratumumab overcomes the detrimental effect of T1114 when you use VCD. And also, you can see that for amplification 1q21, again, there was no difference. The CR rates were identical, 59%. So it shouldn't be a problem, but in our patient, unfortunately, we are in the 20% that did not achieve a VGPR. So this is challenging. What about 1q21? Already Giovanni Palladini pointed that there are some data, this is an analysis from Raja Kabotri, showing that patients with 1q21 may have slightly inferior outcomes. However, I have to point out that this is not overall survival. This is hematologic event-free survival, so which means that these patients tend to have a higher probability of earlier hematologic relapse. This is different than the overall survival and what happens to the organs. However, we have to remember that although there is a difference here in the complete hematologic response rates, that the presence of 1q21 in amyloidosis is also associated with higher tumor burden. So maybe it's just a variable associated with a higher tumor burden. So, the other question is, should we use maintenance in patients with AL amyloidosis? And what should be the strategy in patients who achieve hematologic CR or hematologic VGPR? And which is the best maintenance? So this is just my personal approach to maintenance. For patients with a complete hematologic response or VGPR and organ responses, I continue daratumumab as per the Andromeda, to stay also with the label. For patients who have also a good response, but they also have myeloma, I'm not feeling very comfortable with daratumumab alone, and in these patients, I try 2 things. Either to see if they are eligible for consolidation with autologous transplantation, which they are usually not, unfortunately, or to try to add in maintenance lenalidomide, because we know that it works in myeloma. I don't think that anyone here can argue that we don't have enough data that lenalidomide maintenance helps in patients with myeloma, whether they have been transplanted or not. So this is what I'm trying to do. So the treatment should also be clone adapted, meaning that we have to adapt for the burden of the plasma cell clone, and also for patients with T1114, of course, we have to adapt by adding daratumumab. If you don't have daratumumab, that is a problem. And we can discuss whether we should consider venetoclax. What about transplantation? So transplantation gives you very good results in the patients who are eligible, but compared to dara-VCD, has lower rates of complete hematologic and organ responses. So this is a good consolidation therapy for patients with tumor burden that is fulfilling the myeloma criteria, and for patients who fail to achieve a good hematologic response. Okay, but it cannot be the only therapy, and there are some recommendations here from the International Society of Amyloidosis led by Vaishali Sanchoravala. And to support the use of autologous transplantation as a consolidation strategy in patients who fail to achieve our goal, this is a study from Pavia showing that you can use this strategy and have very good results without compromising the outcomes of patients with AL amyloidosis. So this is the approach to patients with in the initial therapy. And in these patients in which we failed to achieve response, and the patient had also peripheral neuropathy that is worsening with the addition of bortezomib, what can we do? I mean, we have to stop bortezomib at some point. The patient is not doing well, has worsening peripheral neuropathy. What can we do? And the patient does not have T1114. So we have to remember that the treatment has to be adapted to the toxicities associated with the drugs and the characteristics of the patient. So in a patient with a neuropathy, it's very challenging to institute bortezomib at full doses and even at low doses. We have to be very careful. And some of the drugs that are used are not very well tolerated by these patients. Daratumumab is probably the best tolerated regimen. Venetoclax, I think, is also a very good drug, tolerated by most patients very well. From IMiDs, I think pomalidomide is much, much better tolerated than lenalidomide. But of course, we have to remember that IMiDs are not the optimal treatment for patients with AL amyloidosis. Now, what happens with the relapse? So the definition of relapse is not very well defined in AL amyloidosis, and I think the question here is, what happens if we don't have the response that we wanted, like the second patient or the third patient who did not achieve a complete response or a VGPR? So these are the regimens that we have, okay? But most of the patients now will be exposed to daratumumab. So what happens when you have patients who fail daratumumab? When you have patients who fail daratumumab, one option is to do what Mayo Clinic does. Do transplant, if the patient is eligible for transplantation. Or try to change therapy. What makes a big difference is the presence of T1114. So in patients with T1114, a fantastic option is the use of venetoclax, if you can have access to venetoclax. Because it's easy to use, it's pills, relatively well tolerated, and very, very effective, but again, only in patients with T1114. And also, new BCL2 inhibitors come, such as lisofosflax. Of course, this is experimental in very few patients. And what about ADBCMA therapies? This is a prospective study that we did in patients with relapsed or refractory AL amyloidosis. 75% of the patients had been exposed to daratumumab and were refractory to daratumumab, and they were treated with monotherapy with belantamab mafodotin. The responses are good, because this is a monotherapy in a heavily pretreated population. The problem is here, ocular toxicity. The drug here was given every 6 weeks, not every 3 weeks. And you know, at some point we were very disappointed with belantamab, and then 2 studies came showing that if you add belantamab to either bortezomib dexamethasone or pomalidomide dexamethasone, then you have a very good regimen. Extremely good regimen. And also, belantamab VD was better than daratumumab VD in relapsed refractory myeloma. So I think that this data indicate that belantamab combinations may be a future, because it has not been approved yet for myeloma, a future very good option for patients who may fail either daratumumab or Velcade. And bispecifics. Bispecifics are fantastic. We have very limited experience. They act very rapidly in myeloma. They act extremely rapidly in AL amyloidosis. We have studies ongoing. Very good results, but these are very few and very selected patients. My experience is that when you give bispecifics, during the step-up dose, you already achieve CR. So this is very good, but we all know what are the long-term limitations of bispecifics. What about CAR T cells? I know we are going now to the Star Trek era, and this is just imagination. We don't have access to CAR T cells for AL amyloidosis. These are academic CAR T cells that were used for the treatment of patients with AL amyloidosis in Israel. Very good results, not so good results in terms of response. The outcomes in terms of survival were not so good because many of these patients were treated very late of the course of their disease. So in this patient who, okay, so this is my personal view on the management of the refractory disease. And I think the key here, because I guess these are very few patients, the key here is this, whether the patient has T1114 or not. And for the patients who do not have T1114, I think daratumumab with pomalidomide and VD may be an option. So if you have a patient with dara VCD and you don't have a good response, perhaps if you can add pomalidomide and omit cyclophosphamide if you are very early, it's an option. Or you can see other options which include IMiDs or newer drugs. And this is the final slide about AGM amyloidosis. We don't have to forget that a small proportion of patients, 4% of the patients with AL amyloidosis, have IgM clones. The results are rather disappointing. We don't have daratumumab there. Of course, we have to be sure that this is an IgM clone, it's a lymphocytic clone and not a plasmacytic clone, because we had some surprises. And what we do is that we use bendamustine with rituximab and bortezomib with rituximab maintenance to reach CR. In a few patients, we have used zanubrutinib, which is safer than ibrutinib in terms of cardiac toxicity. And the amyloid deposits, can we do something for this? We have the two studies with KYLE-11 and selatimab, and one study with birtamimab. The studies have completed accrual, and we will have the results maybe before August. And we will see, so I will not say anything more for these studies until we have these results. And with that, I would like to thank you very, very much for your attention and the invitation.
Thank you, Efstathios, for this excellent presentation. Just a comment regarding the difference between myeloma and light chain amyloidosis. I've learned from my experience, and probably you have the same opinion. Light chain amyloidosis is completely different than multiple myeloma. They are not the same disease. Even sometimes we have the same clone, but they are not the same disease. In light chain amyloidosis, we have excellent prognosis, completely different than multiple myeloma. Now we saw this different approach in the clone 1114 translocation. So this is also very interesting difference between myeloma and light chain amyloidosis. My question is regarding Andromeda study. we know it's, I think it's the first and the unique study in light chain amyloidosis, and this allowed approval daratumumab, dara VCD in therapy from light chain amyloidosis. You spoke about early mortality, and we have to say, in this patient, you excluded patient with advanced cardiac disease. So, you spoke about mortality, early mortality, in the first few months. What was the reason for this mortality?
That's an excellent question. So, among the 26 deaths that occurred in the first 2 months, 24 were related to complications associated with cardiac amyloidosis. So this is the main reason of early mortality. Cardiac amyloidosis. It's something that still, it's very problematic, and we still don't do enough. And I think Giovanni showed a slide showing the different outcomes in different eras from 2000, I think, until 2021. And you can see a rapid slope of the survival curves in all 3 eras of about 15 to 20%, which is identical. So yes, we have improved long-term outcomes, but we only improve long-term outcomes if the patients survive the initial 2-3 months. So it takes some time to stabilize the disease. It takes some time to eliminate the light chains and take this toxicity from the cardiac myocytes. Will the new drugs targeting amyloid deposits and amyloid oligomers help? We have 2 randomized studies that we expect the results. We will see. And we have some drugs also in development, some stabilizers in development. So I think what we need is a better collaboration also with the cardiologists, but this may not always be feasible. I mean, it's not easy to suggest early cardiac transplant in all these patients.
Sure, in the room we have some cardiologists here, and maybe we have their opinion. Do you think the patient with any kind of cardiac involvement should pay more attention? I mean, maybe to start therapy without high dose dexamethasone, without or a lower dose of bortezomib, to decrease the mortality?
Yeah, I think this is a very good question. I think for patients with low risk, okay, we can use dexamethasone maybe at 20 milligrams. I don't think that when you have drugs such as daratumumab or bortezomib, you need a lot of dexamethasone. I don't think you need a lot of dexamethasone because also it's a toxic drug for patients with heart failure. Regarding the doses of bortezomib, my personal approach now is to use lower doses at the beginning, especially in patients, for example, who present with more severe cardiac involvement, who present with hypotension. Also, this is a complication that is aggravated by bortezomib. In patients who present with some degree of peripheral neuropathy, they complain about their feet, that they are feeling some pain or some tingling in their feet. I think one has to be very careful. Also, we have to remember that bortezomib is associated with constipation, and we have seen paralytic ileus in patients treated with bortezomib. One has to be very careful. I think if you start with daratumumab and after 1 or 2 weeks, you don't see a huge reduction of the light chains, you could add the second or the third drug. If you do see a very rapid reduction of the light chains, you can continue, follow closely the patient, and then add, if you don't, let's say, achieve a complete hematologic response, add bortezomib. I think we have to be very aggressive on what we want. We want a rapid response, but also we have to be very conservative on how we add the drugs. We have to be very careful in these patients who are very, very frail.
And coming back to the first question regarding Andromeda study, do you think it's
You mean whether in
early mortality?
Well, early mortality is somewhat related to the experience of the center, mainly on the use of the drugs. So, for example, what I have seen is that from centers that are not experienced and they refer patients to us, they start with higher doses of dexamethasone. They give 40 milligrams of dexamethasone. Some of them, for reasons that I don't understand, they even give four consecutive days of dexamethasone. They use full doses of bortezomib. Some of them even use twice per week bortezomib. So these are things that can worsen the outcome of the patient. A second very important issue is that in patients who are referral and experienced, you usually have a cardiologist next to you. And I think this is very, very important, that you have to have a cardiologist who is experienced in amyloidosis and, for example, who will not allow ARBs or beta blockers, who will be judicious with the use of diuretics, who will institute early SGLT2 inhibitors, who will be experienced in managing arrhythmias and conduction abnormalities in patients with AL amyloidosis. So in my center, for example, we have cardiologists specialized in heart failure and cardiologists specialized in electrophysiology, echocardiography, because these patients may need advanced care. And in a small center, maybe this is not easy to do.
Thank you very much. There are any other questions? Please. Andrea Jerkan from Food and Clinical Institute.
Thank you. I also have a question regarding a patient I treated. She has severe many organ involvement. She has heart involvement, renal involvement, digestive tract involvement, also polyneuropathy, pretty severe one. She was treated with DARA RD for around 3 years with around a VGPR response, but now she's progressing, and she's progressing on the digestive tract with abdominal pain, and she repeated the endoscopy, and they see she has ulcerations, and so we have to start a new treatment because she is also having a progression on the hematological disease.
So the patient is still on lenalidomide and daratumumab?
No, she is only on DARA right now because she had to stop it last year after she had a series of infectious disease. She had a COVID infection, then complicated with other infections. So now she's only on daratumumab, yes.
Is the patient having T1114 translocation?
Sadly, I don't know because we didn't do that at the beginning of the...
Yeah, I think this is very important. I mean, if the patient has T1114 translocation, there is a fantastic option, BCL2 inhibition. If the patient does not have T1114 translocation, then the options are more limited. The other problem here is the GI involvement, and GI involvement is very difficult. We don't have criteria for the degree of GI involvement. We depend on how the patient feels and whether the patient has diarrhea or has constipation or has pain or has nausea. So unfortunately, we don't have very good criteria for this. But I think for this patient, you know, if there is no T1114 translocation, pomalidomide-based regimen could be a so-and-so option. If you could get access to ADBCMA therapy, I think that would be the best option. But again, it depends on what you can get access to.
Okay, thank you.
Probably here we can switch the diagnosis of multiple myeloma and we can have better access. Sorina?
I'd like to ask you, is it wrong to use daracybordi for Myo3B? We usually use it because we have many young patients with IL and I don't know what should I start it if not Dara-Cyborg-D.
Yeah, I don't think it's wrong to use Dara-Cyborg-D. There is also a Chinese study evaluating Dara-Cyborg-D in patients with stage 3B disease. But I think that it's better if someone is very cautious. So, you know, adjusting the dose of bortezomib, adjusting the dose of dexamethasone, so going lower in terms of dose of dexamethasone. I mean, when you start 1 week with Dara and the next week you add another drug, let's say Velcade, etc., so you actually use Dara-VCD, you just use it more carefully. I don't think it's wrong, because with daratumumab alone, you do see rapid responses, but you don't see so much CRs in the first 3 months. So that's why in the AMN22 study, we had a provision that if after 3 cycles you don't have a VGPR, you could add bortezomib. If I would design the study today, I would say that if after 1 month you don't have a VGPR, you add bortezomib. So I think, again, we go back to Dara-VCD, we just adjust a little bit the way we use Dara-VCD. So no, it's not wrong.
For this patient, usually we started just with Dexa 8 milligram, and with bortezomib in the first months we give just 0.7
Yeah, so you adjust anyway.
Increase cycle by cycle. Okay.
So you do it anyway. I mean, this is not something that is unique that I'm saying. I mean, we do that in all our patients, even if the guidelines don't say it, even if the SPC of the drug does not say it. We always adjust the doses of the drugs because we mostly know what we should do with these drugs. There are not so many.
And I would like to ask you for maintenance, 24 months of Dara or continuous Dara till progression, or continuous?
That's a very good question.
In Romania, we can give it continuous.
Yeah, so the Andromeda was not designed to evaluate the importance of maintenance. Okay, so we have to be very clear about that. So we cannot say that Andromeda is a study that evaluates maintenance. We know that maintenance is probably slightly better than 6 cycles of Dara-VCD. We do see an increase a little bit of the complete hematologic responses. We go from 53 to 60%. Is this the ideal maintenance for AL amyloidosis? I don't know. Using Dara until I don't know when in patients with AL amyloidosis probably is not so beneficial because most of these patients will be in CR. Most of these patients have small clones, and if they are MRD negative, they have a very low probability of hematologic relapse. If the patient has also some other risk factor, let's say a lot of plasma cells, maybe then these patients may benefit more with additional maintenance, but I'm not sure that daratumumab alone is the best maintenance for these patients. And also we have to remember, we learned this from COVID, that prolonged immunosuppression has also some consequences. And actually, among the major long-term cause of death in patients with AL amyloidosis is sepsis. So we have to, it's something that we see now more and more.
Thank you very much, Efstathios. Excellent presentation. Thank you very much.
Thank you.
Okay.
You have another question?
For IgM amyloidosis, do you think it's better to use this rituximab benda or rituximab bortezomib? For us, it's easiest to obtain rituximab with bortezomib and use it often than rituximab with benda.
Rituximab bortezomib, it's a good regimen, but our experience in Waldenstrom's, which most of these patients have Waldenstrom-like clones, is that it's not so great. You know the ECWM1 study, which compared DRC with bortezomib DRC and found no difference in any of the outcomes. So, but bendamustine rituximab is a very good regimen for these patients, and adding bortezomib to bendamustine rituximab seems to be to increase the complete hematologic response rates. That's our experience, and we are about to send for publication. I'm not sure that bortezomib with rituximab alone is enough to induce a very deep hematologic response. You need to do something more for the B-cell clone.
Thank you.
Thank you very much. Any other questions? No, thank you very much, Statis. And now